Thanks, Professor Ling's kind introduction. In fact, in Taiwan, the most highest variant of liver transplantation is in Kaohsiung Chang'an Memorial Hospital. So I just share maybe young aspect of the vascular intervention before and after liver transplantation. So if the major indication for vascular intervention before transplantation may be the tips or dips. We know that after patient have liver cirrhosis, they may develop EV or GV. Although the tips of this will decrease the bleeding rate, but it increase the hepatic encephalopathy. The same idea is the same as the ascites or pleural effusion. Although ascites decrease, however, the possibility of hepatic encephalopathy increase. So overall, there's no change in survival. And then now I will also learn from many article. And then last month I go to TVSR. They also shift to do that, use a single pass tips or dips. So in this situation, if there is a lesion with HCC or metastasis, it's now no longer a contraindication. And then after transplantation, there may be some complication in hepatic artery, portal vein, and hepatic vein. I will show some cases. And then the intervention will be very determining how long had to be lasting after liver transplantation. Yeah, so in our hospital, the TIS position is covered by National Health Insurance, and then is always under general anesthesia. We need ICU and a cardiac echo before the in the evaluation, and then you need a good ultrasound and a good angel suite. We use a lot of manpower to do this. And then so I show the first case. You can see that he's a 71-year-old male. He is chronic happy. He had esophageal bleeding, have main types of ligation, and then there is a recurrent esophageal bleeding. The male score is quite good. So I think that we can use the CT to evaluate the possibility of tips or dips. And then you can see that there is maybe some branch portal vein thrombosis in the left portal vein and the right portal vein. If you, in such case, if you do conventional tips from use a transjugular approach, sometimes it's difficult to puncture the right portal vein because there's some thrombosis here. So now we will do the single needle pass technique. So under ultrasound guided, you puncture portal vein, then reach the hepatic vein or IVC. And then after that, you can check that if there's blood from hepatic vein and IVC. So we also can check by the IC echo. So you can see that after puncture to the hepatic vein, then I will stand a wire, and then through the neck sheath, we can catch this wire and then do the balloon dilatation. So we create a tunnel from the hepatic vein to portal vein. And then after that, we can insert a larger sheath. So there is a canal. You can pass two wires, and then we wiring to the portal vein, then do the balloon dilatation. So we can put stent. In this way, after this is standing, then you can see that the tips is quite good function. I think in this situation, maybe we can explore the possibility of tips and then very shortening the schedule of the operation time of tips. Because of a shortage of general anesthesia in our hospital, previously we have all day anesthesia time, maybe 8 hours. So we can do tips 4 hours to 8 hours. However, nowadays they only give us half day. So we only have 2 hours to 4 hours. I think that use this single pass technique, and maybe almost all the IR can shortening around 2 hours, which means 120 minutes to accomplish the tips procedure. Okay, and then if there is a vascular intervention after transplant, as we mentioned that it depends on the is a artery vein, portal vein or hepatic vein problem. And then after procedure, because we will consider that do we need to use antiplatelet or anticoagulant? So how is the current time after surgery is very important. For the hepatic artery intervention, usually if there is a hepatic artery problem after transplantation, there is very easy to present with a marked elevation of liver function. And then you need to do CT or MR angiography with coronary reconstruction to see that. We usually, you put a guided shuttle sheath to the celiac trunk, and then there we learn a lot from neural intervention. And then because if you were to put stent, I think that there are a lot of good guiding catheter or intermediate catheter, so to go to the target hepatic artery. And then there is no designable balloon or stent for hepatic artery intervention. So maybe your injury need to prepare some coronary material to do that. And then we will do repetitively indicated. For example, this is a 48-year-old female. She had a HCV-related liver cirrhosis and then received liver transplantation. And then the second day after liver transplantation, there's a marked elevation of the total bilirubin, AST, and ALT. And then use a CT scan, you can see that the hepatic artery may be patterned. And however, if you use the coronary reconstruction, you can see that there may be some problem in the hepatic artery at the aneurysmal site. And then for the portal vein, although there is a small focal stenosis around the aneurysmal site, but I think it's patterned. And then there is segmental the hyperperfusion change around the section area. And then use angiography, you can see that you can see that there is a stenosis around the anatomic site. So in previously, if we only have now we usually use a shuttle catheter at here, so we can have many equipment to use, including stent or ballooning, and then you can see that we can use a small coronary balloon to dilate, although it's only the second day of the operation, but use a coronary balloon, I think you still can do some good coronary balloon dilatation, and then you can see that as compared with the initial angiography, there may be new artery in the inferior portion. I usually, in such acute case, I will not do primary standing or do a very full balloon dilatation. And then I will maybe repeat it next time. And then if it can be survive more than 2 weeks, I will try to do standing. And then for the portal vein intervention, if it happen, usually have very marked elevation of the liver function, and then similar to evaluation method. And then for portal vein, you should consider many kinds of approach into the trans-SMV approach, trans-hepatic, and then trans-planning approach. I know in Kaohsiung Chang'e Memorial Hospital, the surgeon will open the stomach for them and then do trans-SMV approach. I think it's the most efficient way. However, it's not easy in our hospital. And then I usually use a shuttle sheath to do something, and then maybe put a self-expandable stent, and I also use IVUS to check the stent position. So you can see that this is a 4-year-old girl. She had a situs inversus and a dextrocardia and a biliary atresia. And then have received a living donor liver transplantation. So you can see that the heart is at the right side, and then the left side and the right side intra-abdominal organ is reversed. So you can see that this is a spleen, and then this is a lateral segment of the liver. So maybe there is some focal stenosis at the junction of the grafted portal vein and then to the pediatric, the recipient portal vein. So in this situation, I think that if you do transhepatic, it's a very acute angle for the umbilical portion to put a stent here. So I decided to carefully puncture the splenic vein to do the stenting. So you can see that under ultrasound guided, we puncture the portal vein good, and then use the angiography. You can see that there is a focal stenosis at the junction of the splenic vein to the portal vein. And then there is also no specific dedicated stent for this portion. So I also asked neuroradiologist, and then they say that if 6 to 7 millimeter, maybe consider a carotid stent. So I put the carotid stent here, and then as I know that for carotid stent there may be some diameter difference. So I put a larger diameter here, and then a small diameter here. So it can, I think it's good in post procedure angiography. And then how about the hepatic vein intervention after transplantation? It usually, beside the elevated liver function, it may be presented with marked ascites. And then you can do it by a transjugular or transhepatic approach. There's a tips to do a hepatic vein intervention. I usually will put a guide wire in the IVC to mark the location of IVC. I will try to not too much interfere of the IVC, because in that way it may cause leg edema if the stent is compromise IVC too much. So the most important thing is that you need to avoid compromise of the IVC. And then especially for this situation in the junction of hepatic vein to IVC, personally I favor use balloon mounting stent, because I hope to make the stent not migrated. Yeah, so and then if a patient can affordable, I will use IVUS to check the stent position. So let's see this case. This is a 55-year-old female. She had HCV related HCC, liver cirrhosis, and then maybe in the follow-up, there is elevation of the total bilirubin level. And then you can see that in abnormal MRI, the artery and the portal vein seems pattern, but there is the non-med liver pattern, like a heart failure. And then in the coronary reconstruction, you can see that the right hepatic vein is now opacification. So in the venography, you can see that there is a severe stenosis at the junction of hepatic vein to IVC. But I believe that there is a way to go to the IVC. So after putting a wire, it's very easy to reach IVC. So as I mentioned, I will strongly suggest that you put a guide wire in the IVC, so you can know the position of the IVC is here. And then after ballooning, I put a balloon mounting stent here. And then the notch I remain it. I do not like to fully expand it. And then you can see that in the in the post-standing angiography, there is a very good flow back to the heart. And then I will use IVUS to check the condition of the stent. Okay, and then in the follow-up CT, you can see that, yeah, the balloon mounting stent is, as my planning, maybe less than 1/2 of the IVC coverage. And then there is a drug shrinkage of the right hepatic lobe, and then there's a normal non-med liver pattern. In this situation, the IVC will be not compromised and then create a new problem. If you put a very long self-expandable stent, according to our hospital experience, sometimes the stent will compromise IVC, and then you have a new problem. Yeah. So I would like to summarize today's talk in our hospital now TIPS is under general anesthesia, and then we will have a very good post ICU course, and then I will try to use a single pass technique, and then it can be a good way to do that. And then for the vascular intervention after transplantation, I think that dedicated technique and then good image evaluation is crucial. Thank you for listening.